Hi, my name is Pablo Peinado, and I'm an oncology research nurse at the Virgen de la Victoria Hospital in Malaga, south of Spain. I am here today to explain you a bit more about the role of the nurse in the nmCRPC patient and the multidisciplinary team involved in their treatment. An nmCRPC patient is characterized by a rising of his PSA levels after a primary definitive therapy, which could be prostatectomy or radiotherapy, and already treated with the androgen deprivation therapy. In order to select the best treatment for our patient, due to the amount of treatments available and the complexity of the nmCRPC patient, it is required that any case is evaluated from a multidisciplinary team. This team will be made up of some of the following healthcare professionals, for example: urologists, nurses, oncologists, radiologists, radiation oncologists, or psychologists. All of those disciplines should be involved in the diagnosis, treatment selection, surveillance, and follow-up, because it has been demonstrated how the establishment of prostate cancer units could provide financial savings, avoid inappropriate procedures, and improve outcomes, delivering a high-quality care to patients. Thanks to the results from the latest clinical trials in nmCRPC patients, the treatments available for the patients in this stage of their disease has changed a lot, with the approval of 3 new treatments: apalutamide, enzalutamide, and darolutamide. The results from the Spartan study led to the approval of apalutamide, the first next-generation oral AR inhibitor. Enzalutamide was approved after the results from the Prosper study were published, and in 2019, darolutamide was approved thanks to the results presented by the Aramis study. All the studies show a significant prolonged medial metastasis-free survival, reduced risk of distant metastasis or death, and a prolonged median overall survival. Apart from that, the time to initiate a next line of treatment with chemotherapy was prolonged, and both symptomatic and PSA progression were improved as well. You can check the slides from this newsletter for a new, more extended information regarding the results from these studies. As we've seen, there are multiple options of treatment for our nmCRPC patients, so we should be aware of the main characteristics of an nmCRPC patient before deciding which therapy we do want to start. The nurses are a key role during this process, due to the high levels of confidence with the patient that allows them to ask his questions openly and increase their knowledge regarding the therapies available, the possible adverse events, and the prognosis. Usually, an nmCRPC patient will be asymptomatic, without any pain from his disease due to the lack of metastasis on his bone, which is one of the main issues in a metastatic prostate cancer patient. This could raise the question of why he should be treated when he's feeling well, and once again, the nurse figure appears as the most appropriate to show him a full picture of his disease, the current state, and the importance of delaying the metastasis as much as possible. The medical team goal should be maintaining this high quality of life as much as time as possible, and this will only be possible thanks to the therapies presented before. Those treatments will allow us to increase the time until a new line of chemotherapy treatment is required and prevent the skeletal events, pain, and decreased quality of life. After reviewing with the patient the importance of his treatment and the options available, it is important to check the current patient health, his medical history, and current medications. These patients are usually more than 65 years old and polymedicated because of his age-related comorbidities. In order to select the best therapy possible, we should go back to the studies presented before. The most common adverse events presented in these studies were fatigue, hypertension, seizure, hot flashes, weight decrease, bone fracture, and falls. A nurse should be aware of those and review the patient during his treatment to identify those risks and prevent them if possible. For example, some strategies that we could use with a patient with high blood pressure levels could be reviewing them more often and teaching them to keep a record of his blood pressure levels in order to identify any rise. Another useful tool to use could be the quality of life questionnaires to control the fatigue levels during the treatment or evaluate the risk of bone fracture before and during the therapy. At the same time, an initial assessment is required to review the possible interactions of his treatment with the rest of medication that the patient is already taking. Those interactions could increase the risk of suffering adverse events or reduce the efficacy of any of the treatments. Thanks to the information presented in all the 3 studies, we can select the best therapy possible after reviewing the safety profile of all of the 3 drugs and comparing with the characteristics of our patient, common adverse events, and possible drug interactions. With this, we assure the safest and most effective therapy is given to the right patient. To finish, the take-home messages from this presentation will be the high results from the new AR therapies for nmCRPC patients and the importance of involving a multidisciplinary team In the patient treatment selection, the nurses are essential to accomplish this objective. Being capable of assess the patient, inform them, and select the best and safest therapy according to the patient characteristics and the safety profile of the drugs.